Bonjour à tous. Hello, everyone. My name is Tonia Ocionero. I'm the Executive Director of the Canadian Association of Midwives, and I'm joining you from the unceded lands of the Kanien'kehá:ka Nation. I am very pleased to be presenting the Midwifery panel. We have two presenters who will be presenting back to back. Our first presenter will be Dr. Kellie Thiessen. Kellie is a midwife, clinician, scientist who has an extensive clinical background in maternal and child health. She is a registered midwife and the director of midwifery at the University of British Columbia. Today, Kellie will present findings related to midwifery from the Healthy Professional Worker Partnership Study. And that presentation will be followed by Dr. Cecilia Benoit. Cecilia is a scientist at the Canadian Institute of Substance Use Research and professor of sociology at the University of Victoria. Today, Cecilia will present findings from the Indigenous midwifery pilot from the Team Primary Care Training for Transformation study. And we also have Angela Freeman with us, who's a midwife and will be the discussant. So she will moderate a bit of a discussion and some questions and answers if we have enough time. So I will pass it over to Kellie to begin.
Thanks, Tonia. It's nice to see you in person. I've seen your name a lot, so it's great to see you here. Thanks for being here. Yes, as Tonia said, my name is Kellie Thiessen. I'm calling in today as a guest from the unceded territory of the Coast Salish people in Vancouver metropolitan area. Thanks for joining us today. This study that Ivy has led has been sort of a sojourner study where there's been lots of stops along the way, and we started pre-pandemic, so it's been a rich experience all the way around. I'm going to share with you today the findings from the midwifery case study as part of the Healthy Professionals Worker Partnership Project, which has the acronym of HPW. So today I'd like to share our case study findings from this project related to mental health, leaves of absence, and return to work. These findings are reflected in our recently accepted publication in the Canadian Journal of Midwifery Research and Practice, and I think that's coming out either this month or next. A little background before I start. The HPW is a CHR and SSHRC funded initiative that's employing a comparative perspective, as most of you know, to examine the gendered nature of mental health, leaves of absence, and return to work experiences. The midwifery case study is one of 7 professional case studies across the spectrum. The partnership also has a cross-cutting focus on leadership. I'd like to acknowledge our project lead, Dr. Avi Bourgeot, and the midwifery case study was also co-led by myself and Dr. Cecilia Benoit. We had an outstanding core case study team throughout that really pulled a lot of weight through ups and downs and just were tremendous colleagues, and I really appreciate this team. Elena Nederman, Jelena Atanakovic, co-investigators Kelly Gregory, Henrietta Akumoa Boateng, and Angela Freeman. Carolyn Chamberlain were former trainees. Andrea Mellor was a postdoc that joined us towards the end to really support us getting the paper published. So thank you to each one of you. While our research approach involved 5 key sources of data, as seen on the slide, our paper, we report survey and interview data gathered from midwives and midwifery trainees. The findings helped us understand what aspects of midwifery work shape the mental health of midwives across Canada. So turning to the key demographics of our survey respondents, we see that a total of 160 midwives and 39 midwifery trainees responded to the survey between December 2020 and May 2021. 3 respondents identified as retired, and thus we are not including them, giving us a sum of 202 total responses. You can see the demographics here: 9% identified as racial, 5% as Indigenous, 5% as living with a disability, and 30% of the respondents declared themselves as the sole income earner in their household. And within that 30%, if we look at those who live with others, 18 of those midwives declared themselves as the sole earner in their family. The province of respondents included the distribution from Ontario, with a substantial portion from Ontario, and then British Columbia, followed by Alberta and Quebec. We conducted 44 worker interviews with the midwives and trainees. Of those we interviewed, 13 had taken a leave of absence, so about 30%, and participants were from 7 different locations across the country. Most identified as women, with a subset identifying as non-binary and gender non-conforming. With the help of our survey respondents, we were able to understand what percentage of midwives might be experiencing mental health issues and the pathway that workers might take when suffering from a mental health challenge. As mentioned before, the survey also involved workers from academia, accounting, dentistry, medicine, nursing, teaching, and leadership. So we were actually able to make comparisons between the results of these other professions, as seen in the gray bubbles, and those midwifery respondents are reflected in the red bubbles. In doing so, we found that midwives and midwifery trainees reported the highest percentage of mental health experiences in comparison to other professions. This can be seen in the first row, the bubbles on the left, where 58% of the 2,185 professional workers reported mental health issues. Below that were 79%, or 159 midwives, reported mental health issues, a difference that is significant. Moving to the right, we have the rates at which workers made changes to their work to address their mental health concern, which is calculated out of those who suffered from mental health challenges. So here the numbers reveal a slightly lower rate among midwives at 55% when compared to the professional average of 60%. And then in the center row are the rates at which workers considered taking a leave of absence, and this was calculated out of those also suffering from mental health challenges. We can see a close to an equivalent proportion of midwives and midwifery trainees contemplating taking a leave at 59% when compared to 57% of the overall. And yet the most striking difference that we noticed among the results from midwife who related to those who actually did take a leave of absence, where far fewer actually took a leave at 17% compared to the rate of the average professional worker at 31%. And finally, of those midwives who did take a leave, most of them at 70% returned to work at similar rates to the professional average of our sample at 76%. So let's look now at the results of our interviews with the midwives and the trainees in the midwifery field. Our interviews with these groups showed that the burnout is the most prevalent mental health challenge and that work-related factors play a significant role. At the individual level, impacts of aging manifest as having a reduced capacity for the physical nature of the job to recuperate after long shifts and adapting to the sudden changes associated with the pandemic. Midwives also describe their personal mental health challenges as adding a layer on top of the challenging aspects of our work. At the familial level, caregiving responsibilities dominated the responses, in addition to a lack of support and understanding from family members and the relational challenges that can arise from this. And then at the work and organizational level, midwives describe the challenges of managing bureaucracy when seeking support or accommodations, interprofessional dynamics, including bullying and harassment, integration into the hospitals, and the differing larger professional beliefs of what it means to be a good midwife. There's lots of tensions between patients' needs versus midwives' needs. For example, continuity of care versus shared care models, which tend to be connected to the notion of work-life balance. Work content related to critical events or incidents, emotional and ethical challenges, and working with complex or vulnerable populations were identified as sources of stress. While work context related to the demands of heavy workloads, on-call work, and inadequate time off, as well as personal autonomy and control, were leading topics discussed in the context of mental health causes. In some provinces, a lack of flexibility in models of care, employment, remuneration resulted in heavy workloads that contributed to stress, in addition to challenges related to adapting work to accommodate personal, familial, and mental health needs, such as having no choice but to enact on-call work or practice full-time in order to be regulated, employed, and or to accrue adequate remuneration. I've selected a couple of quotes to share with you from our interviews with midwives related to individual work, professional, and organizational factors. On an individual level, one midwife shared, and the real tipping point was when a colleague asked me if I could be available to work Christmas, be on call for Christmas Day. And being the first year in this new family setting where I'm now looking at spending every other Christmas by myself, that was just too much to ask. It was the straw that broke the camel's back. And as it relates to the organization of the profession, another midwife shared with us, there's also a sense of this in the midwifery community. Oh, you don't do full scope, antepartum, interpartum, and postpartum, so I'm a lesser midwife because of that. Here you see some of the survey results related to mental health support and midwives' perception of support from their supervisors. Along the top line, we can see that more than half, or 53% of the midwives, agreed or completely agreed with the statement that their supervisors take time to talk to them when they are upset, whereas almost half disagreed or completely disagree that their supervisor recognizes when they are not acting like themselves. And on the bottom line, we can see that more than half disagree or completely disagree that their supervisors led them to helpful resources. Here we can see the top 3 reasons that mental health leaves of absence were taken among midwives, with the top reason being that the mental health issue was not viewed as severe enough or warrant a leave, followed by financial reasons and there being a lack of replacement for a midwife at work. Next, we look at leaves of absence. Our interviews suggested that the leaves of absence for mental health reasons can be challenging. Enablers to taking leaves of absence included supportive colleagues and access to locums, as well as access to benefits and economic viability. However, it was also noted that some considered but did not take an LOA, citing mental health stigma, a lack of access to locums, lack of organizational or institutional support, guilt, and reluctance due to anticipated impact on colleagues and clients. Participants also identified a lack of economic viability in taking a leave and discussed challenges related to building a caseload after returning as barriers to taking the actual leave of absence. Some midwives described that they would have taken a leave of absence, but instead utilized lieu time and vacation days. They took education leave, sometimes relocated to a different province, or simply left the profession entirely. Here we can see the results from our survey describing the top 2 facilitators to taking a leave of absence from work for a mental health issue. As echoed in our interview data, survey respondents identified supportive colleagues and financial coverage as the most important supportive factors for taking a leave of absence. I'd also like to share some quotes related to perceived mental health supports. One midwife described, I just sat there crying in a meeting, like the tears were just falling on my face. And my dear partner said, give me your pager. She took my pager from me. She said, you go home, you take care of what you need to do, you need time off. And so they were so supportive of that. She actually took my pager away from me. I was able to take some time. They were so supportive, my practice was. Another midwife told us the Midwifery Association was an important resource. We have a member assistance program which is run by our association, which offers employee assistance program. The majority of the reasons that people call is for access to counseling. There's financial planning, legal, and other stuff that's available. And looking at the return to work interview data, now a gradual return to work was the most prevalent enabler described by midwives that facilitated successful and sustained returns from leave. Formal policies and accommodations can support a gradual return, such as the opportunity to conduct administrative, managerial, or other non-clinical work, taking time to refresh clinical skills, working as backup for colleagues, taking on shorter or no call schedules, part-time caseloads, or only very low risk patients, and presence. Support from managers and colleagues was also noted. The barriers to return to work cited by midwives include a lack of change to the work situation attributed to causing the leave and a lack of accommodations or flexibility in their model of care, such as an absence of formal policies or practice protocols, resulting in immediate return to full caseload or midwives having to leave the practice. Our stakeholders identified a lack of coverage and our support from colleagues as barriers to gradual return to work, which was often easier in larger urban practices in which workload and type of work flexibility was accommodated. Some midwives cite the lack of formal return to work policies for those on leave as a contributor to attrition, which can look like leaving for another province with a different practice model or leaving the profession entirely, as I spoke before, for unrelated work. Stakeholders connected these factors to the contrasting models of employment where independent contractors may have less support when compared to midwives who work as employees for a larger organization with formalized leaves of absence and return to work policies. Looking to midwifery trainees now who identified access to student health benefits and supportive classmates and preceptors and family and friends as enablers in mental health. While the demands of their academic programs being on call and relocation, as well as a lack of support from professors and administration as barriers to the mental health. The most commonly cited barrier, however, was a lack of support from the preceptors. This is a big problem in our profession. Students described an imbalanced power dynamic, lack of standards for workload, being discouraged or penalized for taking the regular allotted time off, a culture of generational mistreatment, bullying, and racism, and a lack of support from their institutions when seeking help with challenges related to preceptors. When asked about leaves of absence, midwifery students described a lack of flexibility and course structure as a barrier to taking leave, citing small sizes of the program as a reason they could only take a full year. This process was described as bureaucratic, stigmatizing, to be a full year behind your cohort that you started with. Additionally, students who had to leave halfway through a set of courses described the emotional and financial challenges of having to redo these courses and beginning again. Finally, we explored midwives' intention to quit. We see some of the results from our survey on the intention to quit here. Organization or practice shown in red, and then their intention to quit the profession shown below in pink. Our data suggests that more than 35% of respondents agreed or completely agreed with statements describing their intention to leave their organization or practice, and more than 35% agreeing to completely agreeing with statements describing their intention to leave the profession. At the end of the interview, we offered our participants an imaginary magic wand and asked, how would you use it to improve the work and lives of midwives? A broad and insightful range of ideas were collected. And here you can see provide or improve child care support, facilitate workforce accommodations, establish funding to support leaves of absence, plan structured and gradual return to work processes, and then a review of the midwifery education programs from the perspective of the student. Key findings and points of discussion: many factors at an individual, professional, and organizational level impact mental health. As you can see, we did not explicitly report on employment models, but the data point to employment models as a reason for the worsening mental health of midwives. Long shifts, work-life balance, model of care, burden of working in a group practices contributed to poor mental health. Trainees were also feeling the stress of the burnout, so we're burning out our students before they even hit full-time midwifery. We want to explore today and are interested to understand more about what kinds of interventions that could be realistic and the impact and how that could shift the culture. But first, I just want to quickly take a moment to acknowledge funding partners in this project led by Ivy. It was funded by the CIHR and SSHRC. We'd also like to thank our partners in research, including the Canadian Association of Midwives, as well as numerous provincial level associations and midwifery education programs who have supported this work.
Thank you, Kelly. Maybe we'll move on directly to Cecilia's presentation before we open it up for questions and comments. Kelly, are you presenting Cecilia's slides, or would you stop sharing your screen? Great. So Cecilia, you should be able to share your. Great. You're muted, Cecilia.
And Cecilia, you're on the screen with presentation mode, not so just if you could switch.
Okay, just a second, sorry.
No worries.
that okay right now?
No,
You're still in presenter mode.
So sorry, what should I be on? Okay.
just in full screen for the presentation as opposed to presentation mode.
No. Sorry, I'm not. Wait a minute. So I open up my PowerPoint and
Maybe just, like, are you working on two screens? Yeah, I think just if you go to your PowerPoint and then we can just change the slideshow options.
so
So if you go to PowerPoint, not in presentation mode. Is that on a different screen?
yeah, maybe that's the problem, eh?
Yes, yeah, so maybe just put it to the right screen and then we could do it in. So stop sharing and maybe share another screen.
Are you able to stop sharing your screen, Cecilia? Yeah, there we go.
Can you open it or should I? Okay. Yeah.
If you click share and perhaps just share the PowerPoint itself. I will, I think I have a copy, Cecilia, of your presentation. Let me see if I can help.
That's it?
Yeah, and then maybe if you just go to slideshow and setup, do the setup slideshow. No,
This work?
no, if
Yeah.
you can go back to just escape out of that. If you go to setup slideshow, a little bit over, nope, just on the bar, just scroll up a bit, set up slideshow. A little bit over there.
Oh, yeah, sorry, yeah.
And then click off use presentation mode. So right at the bottom there between the okay. So click that off. No, just try that again. Over to setup slideshow. And there it has use presentation mode, which is just above the okay. Uncheck that. Perfect. And then now try. So click OK and then do your slideshow from the beginning. So maybe click that again, slideshow from the beginning.
No, it doesn't want to.
Okay, so let's escape out of this again. And let's go back to. So if you open it up, it's just, I think you have on two screens. So maybe if you share the other screen, but here we could set it up. So go to slideshow setup. Slideshow. The setup slideshow. And where it is slideshow monitor, click on that, and instead of automatic, so just above the okay, up, yep, right there. And then use primary monitor maybe. And then try slideshow now. See whether it's on the monitor that you are. Perfect, that's it. Here we go.
Okay, so sorry about that.
No worries.
Okay, yeah, so just as a follow-up to Kellie's work, I'm going to just talk a little bit about project that we've had on the go here in Victoria. And I want to acknowledge Andrea Miller, she's my postdoc student, and Natalie Panbaum and Melanie Mason are our midwives, Indigenous midwives, who've been working with us on this project. So just to the territorial acknowledgement here. So what my work has been here at the University of Victoria, and we acknowledge the Algonquin speaking people and the people who live in the Songhees, the Squamish and Wasonic people whose territory that we work on. So the presentation is just an overview of the team primary care, our emerging midwifery project, and some next steps. So Ivy has been the lead on the team primary care, which is a training for transformation project funded by Employment and Social Development Canada. And it just completed its work, and it brought together a large number of professional and educational organizations to kind of focus on primary care reform and how, which include training as well as practice. So the initial title of the project that I was leading here in team primary care was to pilot the integration of midwives into a comprehensive primary care setting. Kelly talked about the importance of employment models for midwives. They're very limited in Canada. And so this was an attempt to look at a different employment model and what it would be like to have midwives working on salary within a primary healthcare network that was actually focused on youth clients. So this was the Victoria Youth Clinic, part of a network of youth clinics across BC called the Foundries. And their aim there is to improve the primary health care for youth in the province. So we had this idea of an employment and practice model that was different for midwives than the fee-for-service model or a course of care model. Next slide. So the Canadian Midwifery Regulators Council has also called for an improvement in the scope of practice of midwives in Canada. In many places, it's quite restricted, and they wanted to be able midwives to have the possibility of practicing beyond just pregnancy and immediate postpartum, but to also include sexual health, reproductive care across the life cycle. So our project kind of coincides with this new emphasis. So we were lucky when we called for applicants from midwives to join us in this pilot, that 2 Indigenous midwives applied, and they were very interested in employing an Indigenous kind of a lens, Indigenous midwifery lens to this pilot. They knew it was very limited to, a year and a half. So we did hire the 2 midwives on a part-time basis, and they were integrated into a primary healthcare network that was quite interested in indigenizing its care in general, not just with in relationship to midwives. So these midwives came on board to help indigenize the primary healthcare team and their work, as well as their own work that they were doing as midwives. So we had 3 different levels of evaluation, intake interviews and focus groups with staff, and then we had interviews with midwife staff and clients. And then at the end, we also had a similar set of interviews. And we are in the middle of writing up these results, and Ivy will post an article that just came out in Policy Options on this project, and we have another one coming out in the Healthcare Management Forum in September. So the key findings are that when we integrated Indigenous midwives, what we found is that these midwives work very much as not just in the clinic, but they work very much in the community. And so they provided wraparound services to youth. They helped strengthen the primary healthcare team, so it became more cohesive. They definitely enhanced relationships with Indigenous community organizations within the Victoria area. And the youth, when interviewed, felt they received a greater cultural safety, and they actually brought a lot of young people to the clinic that were not receiving care before. Some of them who were pregnant or seeking birth control, but others who are also had questions about reproductive, about sexual health and so on. So we found that comprehensive service provision was made possible through this salaried model. And in our case, it was doubly successful in the sense that Indigenous midwives were able to practice an Indigenous strategy. So our next steps are really to try to spread and scale this initiative. We feel that health leaders must recognize the benefits of registered midwives in healthcare teams and to support policies that enable them to practice to their full extent and their scope. And I can say that these two midwives, through a lot of political work on behalf of our team, but also from our national team, Ivy and others, and also through the work of the midwives themselves, we've been able to find bridge funding for their employment at the clinic, and now the government is developing contracts for them. So we're hoping to have 4 employed midwives, Indigenous midwives in the region, who will be working, providing kind of a comprehensive strategy of sexual health and reproductive care for young people in the region. So in order for this to be possible, we really had to change this outdated narrative, about midwives only taking care of pregnant persons, and that they actually can do primary health care, sexual health, reproductive care in a broader way, and that this is needed. There is a gap for the services provided to youth in the region, and so this is a needed service. The Foundry BC, which is the network of clinics, is now also a community partner of ours, and they're interested in seeing if we can implement this strategy in other clinics across the region. So thank you very much. Sorry about the miss up at the beginning, and pass it over.
Thank you, Cecilia. I've noted many things from the presentations, and Kelly, you were talking about how important the support from colleagues is, and I would add to that we also see it within leadership roles when midwives, separate from clinical work, when midwives try to take on leadership roles, for example, in the National Association, they succeed when supported by their practices and their colleagues. It's such a critical point. I will pass it over to Angela. Angela, are you with us?
Yeah,
I am.
There you
This is
are.
my sound.
Cecilia, if you could stop sharing and then we can see Angela, that would be super.
Yeah, sorry. Yeah.
No worries, no worries. Over to you, Angela.
Okay, thank you, everyone. So thank you so much, Cecilia and Kelly, for your thought-provoking presentations. My name is Angela Freeman. I'm joining you from the Saugeen Ojibwe territory around Owen Sound, which is on the traditional lands of the Anishinaabe Nation, tracing its roots back to the Confederacy of the Three Fires, formed by the Ojibwe, Odawa, and Potawatomi nations. I've been a midwife, although not currently actively practicing, in a large rural Ontario practice for over 15 years, and I've had the privilege to be mentored within the HPW Midwifery team. The high-quality findings in your presentations, Kelly and Cecilia, are really well situated among a growing body of evidence about the high levels of burnout among midwives, not just in Canada, but internationally. And as a midwife and a practice partner, I've seen the ripple effects of mental health concerns, including burnout, on midwives' overall well-being within their relationships, teams, and practices. Your findings are also adding timely new knowledge as alarm bells are being raised by midwives and their associations about unprecedented levels of attrition and ultimately the sustainability of the midwifery profession. Over the years, I'm sure that you've heard these as well, the debates among my colleagues about whether the concerns we're seeing today are due to the changing expectations of the workforce or the working conditions. Is it the student or the midwife or the context or a complex mix? I feel like your presentations today help clearly identify how multiple intersecting factors impact midwives' mental health. including their working conditions and work contexts in which they provide care to their clients. I don't think that we can underestimate the value of knowing that the problem affecting the workforce do not lie within the individual. For all the students and midwives at various career and life stages who were told, maybe you're not cut out for this, or saw their inability to work as a personal failing, we know better now. This information can help us as a profession work to address stigma within our schools, practices, and organizations. And instead of shaping our workforce to fit within a system that isn't working, we need to ask how we can do the opposite. Listening to these presentations back to back, I also really love seeing the tangible connection between what we know now and understand about the health of midwives and how this knowledge is really critical for the design of innovative, culturally concordant, and community-driven midwifery care models. 2 weeks ago, I had the opportunity to attend the Association of Ontario Midwives Conference and one-day roundtable focused on the sustainability of the midwifery profession in the province. And over 2 days, midwives dreamed up beautiful sustainable futures, which many include addressing inequities and power imbalances, creating flexible working models, improving system integration through supportive policies and funding mechanisms, essentially echoing and validating exactly what you have reported here. So being at the conference and that roundtable not only impressed on me the critical state the profession is in and the urgency of change needed, but also how dedicated midwives are to doing the work, to building the knowledge, and to changing the system. But what I really think is important to recognize is that the workforce can't do that alone. They need support. So thank you again for sharing with us some insights and recommendations for next steps, including the structural and cultural shifts that are needed to support midwives to stay healthy. As we open up the floor to discussion today, I'd like to ask us to consider what broader impacts of this work can we carry forward, and what takeaways should there be for our professional associations, midwifery education programs, benefits providers, and policymakers. Thank you. So between Tonya and I think that we can field the questions within the chat. If you have a question that you want to, feel free to raise your hand. And also, if you wanted us to read it, you can place it in the chat.
Yeah, exactly. So I'm monitoring the chat and any hands raised.
I may just ask a question while people are contemplating different questions, and maybe to Cecilia. So this, you were presenting sort of on a spin-off project, and I'm wondering how that was linked and built off of what Kellie presented specifically on models of care. So, you know, what would you say? And I'd be curious to get, you know, Tonya and Angela's comments to that connection that you made explicitly between the pilot project and what we were finding from the Healthy Professional Worker Study.
Yeah, I think the healthy, it's a good question, Ivy. The Healthy Professional Project, you know, we really, I think we see a lot of similarities to other professions, but midwifery profession is quite limited in its options, its work options. So it was established as a profession in different provinces and territories. And outside of a few examples and most of the opportunities, there's kind of a course of care model, or where people have to set up their own practices. Many provinces and territories, there's not even support from the healthcare system. And so midwives they have very limited opportunities for employment. We see that in physicians as well, but increasingly we get these different employment models in physicians. So I think coming out of our bigger study, we realized that, you know, we need to deal with the burnout. We need to deal with the challenges midwives are facing, and one way to do that is to give them some career options that are that can lead to working collaboratively with other professionals or our health professionals, with being able to practice using their full scope, their educational, their education and then scope, and for Indigenous midwives to be able to actually work to improve, to provide equitable care in the community. It has to look different for different groups because the care needs are different. So I think that the employment connection is really a big connection here.
Thanks.
Kelly, you wanted to respond?
Yeah, just something that I've been learning more recently in terms of, like as it relates to even the work that Cecilia's been doing in Victoria, is that the critical role of the professional association. I think BC has a standard, and I think probably Ontario as well, but the professional association is really business oriented, and here run by somebody who has a business background. So the executive director has an MBA and she's not a midwife. She comes in as a powerhouse and is out negotiating. And I think that is the role of the professional association. I think there's professional associations that are just sort of spinning and trying to figure out, well, how do we support the profession? Let's send a letter and do that. But there's a really robust way professional associations can be working towards these changes. And I think those associations need to be talking to each other to create that same framework across the country, because I see things happening here in BC because of the professional association.
And maybe I'll add to that, Kelly, around the role of the National Association, which is a little different. We don't negotiate working conditions, but I think we're really trying to push the envelope with the federal government and Health Canada to make them understand the role of midwives in sexual and reproductive health. It's not just about maternal and newborn health. Midwives providing abortion services, midwives as vaccinators. But I can see from your presentation as well, Kelly, that there's still work to be done around the midwifery community and those, I'll call it judgments around, oh, well, if you're not the full scope midwife, you're not really a midwife, meaning if you're not doing, the prenatal birth work and postpartum. And so I think there's many levels of work to be done. Unfortunately, in Canada, midwifery is still quite a young profession in terms of a regulated profession. The last province, PEI, was just implemented midwifery this year. And so we do have the big three, if I can call them that, BC, Alberta, and Quebec, who are organized. They have, staff and executive directors to really lead that work to advocate for better working conditions and better scope. But unfortunately for the other jurisdictions, and which is the majority, they're still so small and volunteer run. So it is very difficult. I'm just checking.
Oh, I'll just agree. Just quickly to say, I think the erosion of morale has to be addressed at a fundamental on the ground level, that we have to work at restoring relationships within our own profession, because midwives don't even like each other. And that is very palpable as in terms of someone that's leading in midwifery, and we need people in leadership capacity, leading in a healthy, restorative way.
If I could pick up on some of your comments, Tanya, especially vis-a-vis the federal government, because this has come up with other professions. So for example, not including midwives in the student loan reimbursement for working in rural and remote areas, which was initially offered to physicians, nurses, and then subsequently to physiotherapists, and how that speaks to this lack of recognition of the profession, which is very telling in an international context, vis-a-vis how midwives are situated within the UK or even in the US. So I'm just wondering if you could kind of speak to that, and that kind of weighs heavily on the profession.
Yeah, I mean, there's so many issues, but I am happy to report that we finally, after 10 years, have been included in Canada's Student Loan Forgiveness Program.
Okay, great.
It was announced in the 2024 federal budget, so that was a big win for us, again, as a way of incentivizing midwives to work in rural and remote areas, and we know that there are many. And again, in these smaller, you know, I think of the Northwest Territories and the expanded scope of practice of midwives in the territories, the birth numbers are lower. So they do well woman, well baby care, they you know, do pap testing and contraception counseling and so many things. And so this is what we're working at all the angles to change policy to enable more midwives to be doing this type of work. Again, it's tricky. Our health system is complex. We're working with 13, I'll say 14 jurisdictions because the federal government plays an important role. We also work very closely with the National Council of Indigenous Midwives. They're doing a lot of great work to also change the pathways to becoming a midwife and what does it mean to be a midwife and what are the services that you offer to be called a midwife. So, and they're working closely with the Regulators Council as well. So lots of work ahead of us. Yeah, but certainly, you know, what we're trying to do at the national level is change the policies that need to be changed. I mean, at the federal level, the Treasury Board still doesn't have midwifery recognized as an occupational classification. So sometimes it feels like we're really starting from the ground up.